This program is brought to you by Emory University.
We have a real treat with us this morning. We've got two people who are presenting. One is Dr. Adam Mitchell, who everybody knows. He is an assistant professor here at Emory, did his internal medicine training at University of Minnesota, followed by the clinical investigator pathway in cardiology here at Emory, and then joined us and has been on faculty for 2 years now. He also co-directs the LDL apheresis program. Adam has been very active on the Hearst and Consult service, has passed 2 board exams, became a new dad, and actively doing research. It's just amazing that he's been able to accomplish all these things in just a year and a half. We have Dr. Cecile Janssen, who he has invited, Dr. Janssen is a professor of epidemiology at the Rollins School of Public Health. She received her master's and doctorate from Erasmus University in Rotterdam, the Netherlands. Dr. Cecile Janssen has a research focus on translational and predictive genomics and the ability of polygenic risk scores to predict disease. She's very interested in research methods and statistical modeling, and she'll be discussing what Adam talks about today. With that, I'll turn it over to Adam.
So thanks for the opportunity to talk about this today. I wanted to at least acknowledge that it feels somewhat silly to talk about almost anything right now, given everything that's going on in the world, and this is my way of doing that. When I first thought about presenting on this topic, I wanted to kind of think about practical ways we might be able to start using polygenic risk scores in clinical practice. And I also wanted to think about ways that maybe, or reasons why we may want to be careful about doing this. And the more I started to read, the more I saw the name Cecile Janssens and recognized that she was right down the road. And I've since read a lot of her work and listened to some of her talks, and I think she's brilliant. And I wanted her to, tell us what she thinks. So I'm really excited that she accepted my invitation, and I look forward to hearing what she has to say. I have no financial relationships to disclose. So I want to just kind of get through a few things first, make sure everybody understands what a polygenic risk score is. I want to review some of the major studies that demonstrate that there is an association of a polygenic risk score with coronary artery disease. I want to review a couple studies that demonstrate that this genetic risk appears to be modifiable. And then I want to kind of brainstorm about ways that we might incorporate polygenic risk scores into our current strategies for not only risk classification, but also ways we might think about pharmacotherapy and treating patients at high genetic risk. So to review, just where does all this data come from? It comes from genome-wide association studies, and sometimes we lose sight of that. But the basics are is we're going to take a large group of cases and a large group of controls, in this case heart disease, and we're going to genotype a variant. And in this case, we look and we see that there are more C alleles in the cases than in the controls, and we would conclude that this particular allele is associated with coronary artery disease. And for the last 20 years, a lot of work has been done in this area. This is a Manhattan plot. So what we're looking at is on the x-axis, you can think of each dot essentially like a genetic variant or a single nucleotide polymorphism across all chromosomes. And then on the y-axis is a p-value, which is looking at the relationship between that particular variant and its association with coronary artery disease. So the higher up on this graph, the lower the p-value and the more significant the statistical association is. These p-values have to be really, really small because when we're doing these studies, we're doing millions of tests. So you find a lot of statistical associations that would happen by chance, and you have to adjust your statistics for that. So as you can see, there are a lot of genetic polymorphisms that have been associated with coronary artery disease over the years. And we can somewhat arbitrarily draw a line at a given statistical threshold. The idea then is to take all of the genetic variants that are associated with coronary artery disease, kind of dump them into what I see as a complex statistical analysis, which in my mind is a bit of a black box. I just admit that. And then from that, we can kind of put people on a gradient as either high, intermediate, or low risk. You can imagine the more risk variance you have up here, the more it shifts you towards the high risk, and the fewer you have, the more it shifts you towards the low risk. This is interesting. I don't know how many people have done 23andMe. I did it out of curiosity. There's a group at Scripps now that if you give them your 23andMe data, they have an app on the phone, and it's remarkably easy. You give them your data and they will spit out your coronary artery disease polygenic risk. So this is actually mine. I'm in the 62nd 0.5 percentile. For what that's worth. There are also commercial companies out there that are starting to offer not only health-related genetic testing, as has been out there for years, but polygenic reports. And this is one company called MyHeritage. I did this also out of curiosity. They'll tell you about your ancestry, as well as give you a lot of genotype data about health risks, which include polygenic risk reports for coronary disease, high blood pressure, and diabetes. And this is what they look like. So there is at least some consistency between my genetic risk for coronary disease according to this score and the one that I got from Scripps. I have relatively average risks of diabetes and high blood pressure. I came across Dr. Janssens' Twitter feed, and I thought this was a really insightful question, and it's exactly the kind of question we need to start trying to answer if we think we're going to use these in clinical practice. So the question for the doctor is, if polygenic risk scores are considered in addition to clinical risk factors, say for cardiovascular disease, in what scenarios would they change your recommended intervention, and how do we make these decisions? So I'm going to try to address that specific question later in the talk. So first, I just want to go through kind of the argument that's been made for why we should incorporate polygenic risk scores into clinical practice, and divided into 3 or 4 sections. One is that the risk score is independently associated with coronary artery disease. 2 is that adding this score to our clinical risk prediction models improves our accuracy. This is a modifiable risk factor, and that we can speculate that it will improve patient outcomes. So this is one of the first studies from 2016 that showed that polygenic risk score was associated with coronary risk. So this is in the FIN risk cohort, and this particular graph is just looking at men. And what they did is they looked at 12,000 study participants in FIN risk, as well as 3,500 or so Framingham heart study participants. They generated a risk score using 49,000 SNPs, and they looked at its association with coronary heart disease outcomes, which were a combination of MI, CHD death, revascularization, angina, or coronary insufficiency. And what you can see is in people with a high genetic risk, in this case, people in the top 20% of risk, as they move along in age, their cumulative risk for incident CHD is much higher. So they've shown that if you're in the high risk cohort, your cumulative risk crosses the 10% threshold in your early 50s. Whereas if you are in the intermediate risk, you cross that threshold in your early 60s. And if you're in the low risk threshold or category, you cross that threshold in your early 70s. This is looking at men and women in both cohorts. So you can see similar trends. The trends are more impressive, and the curves diverge earlier in men as compared to women. Is this an independent risk factor when we look at other known risks for coronary disease? And the way that they tried to get at this is we look at the relationship here between the genetic risk score and the Framingham risk score, or the genetic risk score and the ASCVD risk score, and what you can see is that there's really no association between the two, which leads them to conclude that this is independent of traditional risk factors. This is a slightly more recent study. This came from the UK Biobank, which is nearly 300,000 patients. They looked at 6.6 million SNPs. And if you just stop and think about the amount of data that's generated from studies like this, it's pretty remarkable in my opinion. What they found is that using their risk score, 8% of the population is at about a 3-fold increased risk compared to the remainder of the population. And of course, the further you go out into your into the tail of this distribution, the higher your risk is. So you may be at a 5-fold risk if you're in the top 0.5 percentile. And what they say is that this risk that 8% of the population carries around with them unknowingly is about the same as the risk as somebody that has a heterozygous familial hypercholesterolemia. This is another figure just essentially showing the same thing, that as your percentile polygenic risk score increases, the prevalence for CAD goes up. This is another, what I thought, really interesting study. So this study compared a cohort of patients who had early myocardial infarction before age 55, 2,000 of them or so. And they compared this to study participants in the multi-ethnic study for atherosclerosis, which were healthy patients free of heart disease when they were enrolled in the study. And they asked kind of two big questions. One is, what's the prevalence of the high polygenic risk score in these two cohorts? And what's the prevalence of an FH mutation in these cohorts? And how much of the risk for having an early MI can be explained by these two risk markers? So they defined as a high polygenic risk score as greater than the 5th percentile, or the top 5th percentile. In the control group, as you'd expect, 5% of people had a risk that high or a score that high. And when you compare that to the early MI group, they found that 17.3% of that group had a high polygenic risk, which I think really supports the association between these genes and coronary disease. And they calculated out that this translates to about a 3.7-fold increased risk having this high polygenic risk. They found that in the control cohort, about 0.6% of the population had an FH mutation. In the early MI cohort, 1.7% had an FH mutation, and the risk was about the same, polygenic risk versus monogenic risk. Many, many more people here with high polygenic risk as compared to monogenic risk. So there's been now multiple studies that I think are fairly convincing that polygenic risk scores are independently associated with coronary artery disease, so I gave that a green light. The next one is a question we want to address is, does this improve our accuracy with regards to clinical risk prediction? So one way to get at this question is an ROC curve analysis, and we're looking essentially at the area under the curve. As that area under the curve gets bigger, the better the test. And we can simply ask, if we take our clinical risk models like the ASCVD risk calculator, and then we add polygenic risk score on top of that, how much does it shift our curve? How much does it improve it? And several studies have asked that question. So this is the study from 2016. And here we're comparing the Framingham risk score plus the genetic risk score on top of it to the Framingham risk score alone. And you can see that we increased the C statistic by 0.01, which was statistically significant. And we get about the same results if we compare this with the ASCVD risk score and then add the genetic risk score on top of it. So it's statistically significant. The word that I see thrown around a lot to describe these increases in C statistic is modest. And I'm not sure exactly what that means. Two other studies I'll show you, kind of similar results. If we looked at the pooled cohorts equation, that gives us a C statistics of 0.76. If we add the polygenic risk score on top of that, we go up to 0.78. It's statistically significant, but a relatively small increase in the area under the curve. This is the same type of analysis from the UK Biobank study, and you can see we increase our C statistic from 0.67 to 0.69. So I think it does improve our clinical risk models. As far as the magnitude of that improvement, I'm not sure what to make of that, and I'd be really curious what Dr. Janssens thinks. It's statistically significant, but I guess the question is it clinically meaningful? So the next question we want to ask is this polygenic risk score, is this modifiable? Is there anything we can do about it? So one way that people have tried to address this question is they look back at primary prevention statin trials. So in this case, here's the Jupiter trial and the Ascot trial. So these were trials where healthy people free of heart disease and relatively normal cholesterol were given statins for primary prevention. And what they did is they separated them out by genetic risk, and they showed that the study participants with a high genetic risk actually derived the most benefit from statins, whereas the people with low risk derived very little benefit. So that's interesting. This type of finding was reproduced in a different statin primary prevention trial, and they showed that patients or participants at high genetic risk had a more significant risk reduction than those at lower intermediate genetic risk. So it does appear that statins are more beneficial in patients at high genetic risk. What about lifestyle? Can we modify genetic risk by lifestyle? This is a paper that tried to get at that question. And by lifestyle, they focused on 4 things here: smoking, obesity, physical activity, and diet. And what they show, if this is in 3 different cohorts, but if you just focus on this one for simplicity, we're looking at this red bar is somebody who has an unfavorable lifestyle and high genetic risk, whereas this blue bar here is somebody with a favorable lifestyle at high genetic risk. And you can see that their 10-year coronary event rate is much different, and that this trend holds up in multiple cohorts, which suggests that yes, if we can convince people to stop smoking and live a healthy lifestyle, that we can overcome some of this genetic predisposition towards disease. So I gave that a green light and a check mark there. I believe it. So when we start thinking about how might this look in clinic and in the population, what you realize is if you took 1,000 patients, we would expect about 6 of those 1,000 patients to have a monogenic FH. And we can find those people through cholesterol screening. And that's a big reason why we do cholesterol screening, is so that we can identify these people at high risk, which we estimate to be about 3-fold greater than the general population. And we think it's really important to find them, to counsel them, and to start them on medications early. If we think about polygenic risk, in that same 1,000 patients, there's probably 80 or so that we would have as classified as high polygenic risk at a comparable risk to these FH patients. The difference is we have no way to look for these participants. Their cholesterol is not high. They look like healthy people. The only way to know if they're at high polygenic risk is to do the genotyping. And the question is if we're going to, take measures and be aggressive about modifying the risk in these patients, shouldn't we also be doing it for these patients? And could we potentially have a much bigger impact, given that there's so many more people out there with polygenic risk than monogenic risk? So how do we currently approach coronary disease risk prevention? This is a recent paper that kind of summarized our methods for going about this. When we see a patient in clinic, we want to think about what is their 10-year ASCVD risk. How likely are they to have disease over the next 10 years? And then we want to categorize them as low, intermediate, or high risk. We have a discussion with them about what we think their risk is and things that they can do to modify that risk. If they're borderline and we're trying to decide, should we put this person on a medication, we think about getting a coronary calcium score to help further risk stratify them. Notice also that when we're having this discussion, we don't just focus on the 10-year ASCVD risk score. We also consider risk enhancing factors. And some of the risk enhancing factors are family history, high cholesterol, metabolic syndrome, CKD, inflammatory conditions, some biomarkers. You can consider high-risk ethnicities, women with premature menopause. And I'm wondering, should polygenic risk score be included on that list as a risk-enhancing factor? Possibly. This is just a screenshot of the ASCVD risk calculator and the way that we try to calculate this risk for patients. And I often do this with a patient in front of me on the computer, and we do it together so that they understand kind of my thought process. So when I go back to Dr. Janssens' Twitter post here, I can look at the 4 hypothetical patients that she listed, and I can kind of easily separate them out in my mind. The patients on the right, number 3 and number 4, I would they look like higher risk patients to me. They're a little bit older. They have some risk factors that she's listed here, like high glucose or a high BMI, high cholesterol. So these are the kinds of patients that if I saw them in clinic, I would be thinking about what is their risk. Does this person, should they be on a statin? Would they benefit from a statin? Do I need to do more screening? Would they benefit from a calcium score? So I'm not sure how much the high polygenic risk score would help me, but I do think, given what I've learned over the last couple of months, it would probably sway me and make me a little bit more likely to recommend a statin in a patient who might be on the fence. I would still calculate their ASCVD score. If they were hesitant about taking a medicine when I thought it was to their benefit, I would get a calcium score to help further risk stratify them. But I do think knowing this information would make me a little bit more likely to push medications. This is a tougher question, I think, is what do we do with a younger person who's got no risk factors but a high polygenic risk? How can I counsel that person? Well, healthy lifestyle, but I'm going to tell everybody that they should have a healthy lifestyle, regardless of what your polygenic risk is. I'm not going to tell people to start smoking cigarettes. One thing you might be able to do is say, well, if you're at a high polygenic risk, maybe I will get a calcium score on you earlier than I would have, and look for disease earlier than perhaps I would have thought to do. The other interesting question is, would you put somebody who's young and at a high polygenic risk on a medicine, on a statin for the rest of their life? Is that crazy? Well, I don't know. I started thinking about this. If I had a 30-year-old healthy person in front of me in clinic, how would I talk to them about this high polygenic risk that they were found to have? I would go back to the data that we have, which are from 2 statin trials, Jupiter and Ascot. And these are trials in older people, mean age of in their early 60s, early to mid 60s, with relatively normal cholesterols. And what they showed is that the number needed to prevent a major adverse cardiac event over 10 years in the high risk group was in the range of 20 to 25. So I would use that as a starting point in my discussion with this patient. And I would speculate that if we started a patient earlier in life, perhaps at age 30 on a statin, that maybe this number needed to treat would be lower and that they would derive some benefit. And I would try to explain to them that the goal here would be to bend this curve from high risk down to a low risk, and that the hope would be that a statin would do that. But I think I'd also have to be honest that I don't have any data, and that I am taking data from other trials and other patients and other situations and trying to apply that to their situation. The costs of starting a medicine when you're 30 years old, of course, there's a financial cost, but there's also this concept of medication disutility, or just the inconvenience of taking medications. And people study this, and I've read a couple of papers about it and find it pretty interesting. There's a subset of the population that even if you told them taking a medicine every day would save them 10 years of life at the end, they don't care. They don't want to take the medicine. It's not useful to them. And so that's where having a good discussion with the patient is important. And then the other potential costs are side effects of statins, which we all know come up frequently. I started to think about how crazy is it to have somebody who's 30 years old take a pill every day for the rest of their life. And I realized that my wife takes a multivitamin every single day and has for years. And I asked her last night how often she misses her multivitamin, and she says never. So a huge percentage of the population out there is taking a pill every day without a whole lot of evidence that there's benefit. So there's clearly some psychology involved here. The other thing to think about is that treating these patients at high risk from an early age may not have to involve taking a pill every day. And so this is just some data from a therapy that's in the works. It's called inclisiran. This is an RNA inhibitor drug that targets PCSK9. And what you're seeing here is a single dose subcutaneous injection of this medication has a remarkable effect on LDL levels for 240 days. And 2 injections over a 240-day period has a very remarkable effect on your LDL. We'd have a long way to go before we started using medications like this in people at high genetic risk. We'd have to show that first that it was beneficial, and then second that it made sense from a cost standpoint. But these are things that are on the horizon and probably worth considering. So that's where I wanted to end, and I wanted to ask Dr. Janssens to kind of give us her thoughts on polygenic risk scores in general, and maybe point out some of the flaws in my thinking if she's able to do so. So I'd turn it over to her.
Okay, I assume you can hear me?
Yes.
It's not the flaws in your thinking, Adam, I think, because you are citing the papers, and I'm going to point the flaws in their thinking.
Okay.
So I have a few slides here that I am going to share. A picture. So the interest in polygenic risk scores is not. We started already almost 2 decades ago with polygenic risk score research. But it's very clear also from Adam's presentation that very recently there's, since the KIRA paper in 2018, this enormous interest again in polygenic risk. And this is a slide from a presentation that I gave just prior to COVID in the UK, where I was summarizing, my 15 years of research in polygenic risk, and I really feel that everybody is going in the polygenic risk direction. And here in this little car is me coming back. Because we have done already 15 years ago a lot of theoretical work on this in this area that made me very skeptical about whether there is so much promise in it. So this is an overview slide that I always show at the beginning of my presentations, the difference between monogenic and complex diseases, because a lot of the optimism that we have about thinking that DNA testing might help is because we are framed from the monogenic perspective, where a mutation in a gene or kind of a repeat has a very big impact on getting the disease. With Huntington being the poster example, when you have a certain repeat in that Huntington gene, you are sure to develop Huntington during your life, and if you don't have it, you don't get it. That is what happens here. Also familial breast cancer, familial colorectal cancer, that is what happens with mutations. But what we are talking about here is not mutations, but variations in the gene. So there's not a good or a bad variance. It really, for some diseases, a variant on a polymorphism is good, and for another one, if it increases the risk for one disease and decreases the risk for another. So it just we vary in most of the polymorphisms. And it is many polymorphisms together that contribute to the likelihood or to the susceptibility of developing a disease under together with environmental or non-genetic risk factors. What I said, this thinking about polygenic risk is not since 2018. It is already started more than 2 decades earlier, and it is started shortly before the Human Genome Project started to deliver. But when they are working to sequence the entire human genome, they were also thinking about what can we do with the other things that we find beyond the genetic mutations. So this is already from the early days. It's for the first papers where they are talking about polygenic risk, not using these words, but talking about it. The early skeptical views is also from that time. So also in that time already, people started thinking about what would it mean and can you use it for screening high-risk individuals. Also the companies, we should also know, so now we have the third wave of DTC companies, also in 2003 and around 2007 and 8. So 2003 were these first companies that did genetic testing for nutrition. They were all gone by 2006, 2007. And then around that time, that was the same time as, when the genome-wide association studies got started. That was also when 23andMe and Decode.me and Abigenics and other companies started. These mostly, except for 23andMe, mostly closed their doors 2012, 2013. And so what we see now in DTC and all the interest is actually the third time that we become very interested in genetic testing. So my curiosity is, will this stay or will this go as well? And do we get a fourth wave maybe later on? So we just heard already about the area under the curve as a measure on how to quantify whether polygenic risk scores add to the prediction of diseases. You can blame me for introducing that into polygenic risk research. We did that in 2004 when I wrote a very long letter to the editor, to the group of Emory from the CDC. And he was really the first to write how we can use polygenic risk for screening of common diseases. And I was just a fresh postdoc at the time. We wrote a 4-page letter to the editor in the American Journal of Human Genetics, showing that his way of reasoning was not how you should think about polygenic risk, but that you really should look at what the polygenic risk means for the entire population, not only for this 1% highest risk or 2% highest risk, because Emory was doing that at that time too. And so for 15 years, we agreed that that was not the way how you should look at the polygenic risk distribution. And now with the arrival of the 2018 paper, we are totally back to looking only at the top 10%, the top 5%, the top 1% of a risk distribution, but that is just a biased way of looking at the potential of polygenic risk. So after this letter, so the AUC was introduced, and we started to look at the entire distribution rather than the tail only. So basically what we're now doing is just starting over with this discussion. Also, what I would like to emphasize is this paper, which was one of the first to really discuss how we can use polygenic risk in practice. And what Paul Farrow and colleagues did was they present a picture of how to use it for mammography screening. But basically they say, instead of doing all the women who don't have a family history, but all the other women in a one-size-fits-all program, we can stratify the mammography screening based on the risk, the polygenic risk of the women. And then here he was basically, they were looking at the age at which women should start with mammography screening, and basically saying, if you are in the high risk tail of that distribution, you should maybe start earlier, and then you are at a low risk tail, maybe your risk will never get to a level that justifies participation in the screening program at all. And so what they were doing then was really looking at how can it improve the efficiency of healthcare, but what we look at now is we only look at the high risk tail, and so basically we are adding care without taking at the low end risk of the distribution. maybe reducing care so that at the population level, we have the same cost investment. So here, the same number of mammographies at the population level, but more mammographies on the women at the higher risk and fewer on those with lower risk, so that at the population level, you improve morbidity and mortality. And so now we have shifted, now people are only focused on the high risk tail, which guarantees is making healthcare more expensive. So all the enthusiasm about starting to use this is, of course, because we researchers, genetic researchers, have discovered so many susceptibility variants in the past 15 years. This is the number of papers. This is a slide that I at one point stopped updating because it went on and on. But what is important to realize is that in 2005, when the first genome-wide association studies were published, that was a genome-wide association study for age-related macular degeneration, which had only 115 patients in it. I think 50 patients, 100 controls, or vice versa. They identified a few polymorphisms that had a 3- or 5-fold increased risk of macular degeneration, were major effects. These days, the genome-wide association studies are so large that they are able to pick up very, very tiny hits signal. So odds ratios, instead of 3-fold or 5-fold, it's now 1.02 that can be picked up statistically significantly. And of course, these very small effects, they are not going to improve the prediction further. So this is in very snapshot how polygenic risk score works. So we just saw already, but I thought let me edit from my perspective. So here you have 10 polymorphisms. And when you calculate that into a score, basically 10 polymorphisms, you get a risk allele, so a risk variant on each from your father and your mother. So either they give you 0 risk alleles, 1 or 2 for each polymorphism. And so when you create what we call an unweighted score, the minimum value, of course, that you can get is 0, and the maximum is 20. And this is what we call an unweighted score. But what people these days mostly do is they create a weighted score. And that is very important when some of those polymorphisms have a stronger effect on the development of disease than others. And when you do that in a population, so here this is an example of an unweighted risk score, you get a distribution, and that's what we also saw. But when it's only a few polymorphisms, and the odds ratios are not really sky high, you see that the distribution of the cases and controls largely overlaps. And what that means is the following. So here you see 2 polygenic risk scores, one for diabetes and one for macular degeneration. Same thing. Here you see overlapping risk distributions, and here you see more separation. And this degree of separation between the 2 curves, that is exactly what is the area under the curve. And this is also exactly the reason why you need a higher area under the curve, because when you want to use a polygenic risk score or any other continuous score for identifying a high risk group, then you want, you always need to dichotomize or maybe make 3 categories of it, but you want that the people who you are selecting for the treatment group, that they are selected by this cutoff score, and that most people who don't develop the disease are on the other one. So when the distributions largely overlap, that's when the area under the curve is low, then wherever you put your threshold for identifying this high risk group, you will make false positives and false negatives. Whereas when these distributions are more separated, then you may have more true positives here and true negatives there. That is what the area under the curve presents, and that is why it's such an essential metric. So how do you get a high AUC is by the strength of association of the polymorphisms that go into the score. Here is an example for hypertriglyceridemia, where they have 7 variants into the score that each have a very large effect on the disease. The 7-fold risk here, the weakest is a 2-fold risk. But as you look at the type 2 diabetes score, the strongest variant in that score, which is one of the first polymorphisms detected by genome-wide association studies, has much less impact than the weakest one for hypertriglyceridemia. And this makes the difference between a low AUC and a high AUC. So then going back to one of the papers that Mark was showing, Adam was showing, sorry, the paper from Kera. So I had enormous trouble with the paper of Kera because I think they brought us back, to studying this, looking at the high end tail of the distribution focusing on the top percentage that would have a monogenic risk of disease, which is not a clinical way of looking at data. But that was not the major problem. The major problem was that the presentation in the main part of the paper was very biased. And so I wrote, together with a colleague, I wrote a perspective on it where we compared where we basically summarized what was in the supplementary file, because they tested 30 polygenic models for each of the diseases that they were investigating. So let's focus here on coronary artery disease. They made one polygenic risk score with only the genome-wide significant variants, 74 variants, and then they had a polygenic risk score with 6.6 million variants, and they tested 30 of those. But this is the area under the curve of the genome-wide significant variants, and this was the highest one of all the 30 others. You see here a very, very minor difference, but that was not so much of interest. Most of the models that they tested in this study, of the 31, most had a very, very tiny increase in the area under the curve, smaller than 0.01, which points us to the fact that what they published in the main paper were the outliers of the distribution of all the models that they tested. And even for atrial fibrillation, most of the models with the millions of variants had worse area under the curve than the one with 55 genome-wide significant variants only. And that's the other side of the story that really got ignored. So why is it possible? Why is it that when you add millions of variants that they don't add so much? Well, it is because when you downloaded all the data, all the effect sizes of the millions of variants, most of them had very, very, very tiny effects, not able to improve the score at all. This is also something to keep in mind. Don't overpromise. Yes, we saw this. We saw this one earlier, and yes, there is a small group of 1%, and maybe you can these ones too, who have a much higher risk than the others. But that's the average. But there's a confidence interval around that estimate. And when you are going to use this model into your patient population, there's also what we call a prediction interval around it, because the model that what we create in research may not be appropriate for your study population here in Atlanta. So there's huge uncertainty around these estimates, and really the predictive value needs to be more extreme to benefit from this higher risk. We also heard in the presentation about independent effects. Yes, that we all observe independent effects, but we should not forget that we create them, the polygenic risk scores, to be independent. Here is an example for coronary artery disease, which have, of course, many clinical risk factors, as you know, but the polymorphisms that are associated with coronary artery disease are associated because they influence those intermediate clinical variables. And so you have blood pressure SNPs, you have cholesterol SNPs, and you have other SNPs for other pathways. But when you combine them all in one potpourri polygenic risk score, then this polygenic risk score is no longer associated to blood pressure and no longer associated to cholesterol, and therefore presents as an independent effect in your studies. So what we should get way more smarter in how we are going to model polygenic risk, and then see that if these clinical factors cannot, to what extent they can mediate those polygenic risk scores, and see what else we can find that really improves the prediction. And this is what I think is a very big gap, and then I almost stopped. Most prediction studies on polygenic risk that are being conducted today is not what you as doctors want. You as doctors want for your decisions, you have to make a lot of decisions for which you don't have enough information, and you do want better predictive tools. We know that. But what they are creating these days in the data sciences is just based on data that they have available, which may not be your clinical population. They just run polygenic risk scores and do some sophisticated analysis, but that may not be the right data that you need for your clinical practice. Because prediction is different from association studies in epidemiology. With prediction, you really need to ask questions. You need to care who is your study population, because this study population needs to be a population in which you need to make your better decisions. Then you need to know in those people, what clinical risk factors do I have available at baseline? What is a clinically relevant time period? Not that now these days we end up with a 2.7-year risk for disease, because that was a follow-up time available in clinical studies or whatever. We need to find out what is a relevant time and what is relevant for the patients and for you to have as an endpoint. And that is how you make a prediction model. A prediction model is really more than putting variables in a model that you have available. And several of the studies that we just show were just missing important clinical risk factors. They were creating some studies, not all of them, creating cardiovascular risk in ways that you don't do it normally in practice. So you make, irrelevant comparisons. And when you make incomplete, irrelevant comparisons, then, yes, polygenic risk may show as a benefit, but maybe not when you do it in a proper way. This is a study that shows, that choosing your study population is so very important. Here is where the researchers applied the same clinical risk model with the same polygenic risk score added to it in 5 totally different populations. And you see that the area under the curve of the clinical risk score varied from 0.62 to 0.80. And in some, the polygenic risk score had a 0.04 addition to the AUC, and some it had none. So this really demonstrates that it really matters in which population you investigate your polygenic risk. And we often see that people use the UK Biobank these days, and that is going quickly back. So I should never do this in a presentation, but this is what you get when you do a risk model in the UK Biobank. You get very, very high area under the curve for most of the diseases because the age difference in the UK Biobank is so large. This affects what we see here, 0.80 for the prediction of coronary artery disease, is because age is a major predictor in that study. And when you have one population where some people are in their 30s and others in their 70s, the people in their 70s are more likely to get coronary artery disease. So I think when we move on, and this is my one but last slide, is we need to do way more relevant studies on polygenic risk, where we really care about all the things that I just mentioned on this slide. And this is the last one. A lot of people get very optimistic about polygenic risk prediction because we tend to focus on how easy it will be to get genomic data from people. Sequencing will be increasingly cheaper and increasingly more accurate, but the price of the sequence is not a factor in how predictive the DNA is. This is the easy part of doing prediction. A more difficult part is to really get very good non-genetic data. So to make it a fair comparison, this needs to be done way better. But the modeling of polygenic risk, where it comes to common diseases, where there's a lot of polymorphisms in there, we now make a very simple score based on this weighted sum score that we did. We don't get it more complex than that, but this is the biological reality that we try to mimic. And that's the difficulty with predicting complex diseases. It's so complex that whatever we try to capture in a formula is such a simple representation of what we really try to mimic that we should not expect that it really gets so much better. And that is, so I think if there's one take-home message that I would like to add here, is that association and prediction are really 2 different things. Yes, we do see that polygenic risk scores are statistically significantly associated with the risk of disease, but that's because we create them that way. We create polygenic risk scores based on polymorphism that we know are associated with the disease. So we should not be surprised that the aggregate, when we combine them all into one score, that the aggregate is also associated. The question is really, can it be used for prediction? And for that we need, as what Adam was just showing, we need much stronger evidence than we have today. Much more relevant evidence, I would say. And to answer one point, so how can it be that a very small increase in AUC is statistically significant? What should we look at? You really should look at the value of the AUC, because especially in these very large populations, everything becomes statistically significant when you have so many people in it. And I always say that, the area under the curve at least needs to improve by 0.05 to see that increment in AUC in clinical practice, where everything is way more messy than it is in a nicely designed study. And let me add there, so that we have maybe, for the people who are still there, a bit some time for some additional questions.
Okay, great. Thank you so much, Adam and Dr. Janssens. If anybody has any questions, it is 8:30.
Yeah.
So if anybody has any questions, we can take them.
Do we know, or are we going to know, if any single risk factors, such as a very young family history, is going to correlate so high with this polygenic risk score that we don't need a polygenic risk score?
I don't know.
Your question is, how well does a polygenic risk score correlate with family history?
No, I'm just saying, is it going to be correlating so highly, such as if you had a young family history, if it correlates so high with a very risky polygenic risk score that we won't need the polygenic risk score itself, we just need that history.
So you're saying the dad has a high polygenic risk, so his son would also be at high risk. We don't need more testing.
Yeah, we don't need any more testing because we already know that they're high polygenic risk, or just the young family history per se is such a high correlation with polygenic risk that we don't need the polygenic risk score.
The heritability of polygenic risk is interesting, and I've thought about this. So monogenic risk is different, right? If somebody has heterozygous FH, then their child has a 50-50 chance of inheriting that variant. But with polygenic risk, if we're looking at 50 or 1,000 or 6.6 million SNPs, if mom has a high risk and dad has a low risk, then my assumption would be the child would be somewhere in between.
Mm-hmm.
So the genetic testing for monogenic diseases makes sense to me because we can do cascade screening, but I'm not sure we can really do cascade screening with polygenic risk. I think everybody's risk is going to be kind of individualized.
Yeah, I agree. And also what we should do things about family history is that it's age dependent. You know, when your kid is still young and you are not yourself as parents at the age that you are likely going to develop the disease, then there are not so many first degree relatives affected. So then you need to rely on an older generation who lived in different times. So it's not the same, the inheritance for common diseases is not the same as for monogenic diseases, entirely different. And also our families get smaller these days. So it is, my mom was one of 11 and had breast cancer and several sisters with breast cancer. But when you have only one sister, you may pass on a genetic mutation even without having, but when you do not have enough family members to express the disease, then family history becomes less informative as a tool. And that is, there are several arguments that I totally can follow the reasoning why we would like to move on to genetic testing. But my fear, my worry is that we start, there are tons of applications that genetic testing is very useful, but that because it is available, we start using it for other things as well. And I think, doctors, that's the thing you need to defend most. We need clinical utility. It's not because the data is available, let's use it.
Hello.
Hey,
hi, this is Arshad. Thank you both for great presentations and viewpoints. I just had a comment and questions. We, with Greg Gibson and his group, have looked at the UK Biobank data in a great deal of detail, a bit like that paper that was recently published. And it turns out, like I think you said, is that if you adjust for risk factors, the area under the curve, etc., is not very impressive. The prediction is only useful at a very young age, it turns out, as I think you also implied from these other studies. But as you get older, there is really no difference in prediction. And the interesting aspect of that is that I guess it's obvious to us now, but very few of the polymorphisms are related to hypertension or lipids and diabetes. Majority of them are unknown as to what they are doing. However, they correlate so well with the development of risk factors as you get older. And so that, I think, is where some of the interest is, or should be, because somehow a polygenic risk score is predicting that you will also develop more risk factors as you get older, because the two give the same information in the end as you get older. But on the practical side, even though I understand all these nuances about what physicians should do and what patients should ask for and what it costs, but if I was a young person, that 30-year-old, and the question is, do I have high risk for heart disease? And should maybe take my aspirin earlier in life, and maybe even a statin if the LDL is above 100. I mean, I'm coming up with these numbers. I think it's very reasonable, because all of the retrospective data suggests that that group is the one that's going to benefit, because with a high polygenic risk score, they are destined to become high risk from risk factors, and that these medicines are going to reduce their risk if you look at this in a retrospective way. Obviously, these studies will take 30 to 50 years to do if you did an interventional study, so that's never going to happen. But that's the only clear way of interpreting this data, is not to use this stuff in older individuals, but to use them in younger individuals. And I would like you to dissuade me from that.
I agree with your statements, Dr. Kayumi. I think it's at least reasonable to give somebody that information at a young age, and then to help them think through what their options are. You don't have to condemn somebody to a statin from age 30 if they don't want to take it, but I think discussing it with them is completely reasonable. And in my reading for this presentation, and I read something that somebody wrote, and they said, most people don't benefit from most medications that we give them, which is true, right? If you look at the number needed to treat for high blood pressure and cholesterol, I don't think most people are actually benefiting. We're treating populations and trying to, in treating 20 people, hoping that one benefits. And so in my mind, any information I can get to lower that number needed to treat and to target my therapies to people that are more likely to benefit, it makes sense to have that information. And so that's why I thought those statin trials where they stratified them by genetic risk were interesting, and could potentially suggest that this would be useful for that reason alone.
Adam, one more question.
Yeah.
How about the insurance companies? What are the chances of their covering, getting a polygenic risk score?
Right now, I would think it would be 0. In the future, I don't know.
No, and the idea is that they don't you don't get a polygenic risk score for one disease, but the thinking is that in the future everybody gets sequenced, and then you can access the genetic data whenever you need it. So that it's a different price view. It's not that for every application you do the test anew.
Right. It's not that a cardiologist would be ordering a polygenic risk score. It's that a patient would come to us with that information already.
Or have it in their records. I do not know how, because it's quite some data. But
yeah.
I think we should, in Emory Clinic, have availability of this. Like Adam, we've been discussing this, and I don't think we've come up with a vendor and a system of how to order this.
Right.
But I think we need to get this done so that people are able to not only just order it, but also have an interpretable report that comes back, so that it's easy for them to use the information. And perhaps discussions like this will teach us who the best population is to order it in. But I think we've been skirting around this for some years, and perhaps thinking of moving forwards would be a good idea.
Yeah, and to your point that it seems like the younger population would be those that are most likely to benefit from this testing, then I'm not sure who would be ordering these tests. The majority of the patients I see in cardiology clinic are older. And if we think that they're probably less likely to benefit from having this information, then who would be ordering these tests? Where would this get done? Is this something for primary care clinics? Or I don't know the answer.
People will come to us if we offer it.
Yeah. Anybody else have any questions? Okay.
Okay, great. Thanks everyone for joining. Thanks again.
Thanks, Pooja.
Okay, bye-bye.
The preceding program is copyrighted by Emory University.